I can't think of a better way to start Breast Cancer Awareness Month than with breaking good news. And the breaking good news came in an article just released a few days ago in the New England Journal of Medicine. As I think you know, the New England Journal of Medicine is one of the most prestigious medical journals in the world. And this is a preliminary result from a clinical trial called TaylorX. The TaylorX clinical trial was designed to include estrogen receptor positive women who were lymph node negative. The tumor size was up to 5 centimeters, and the idea of the clinical trial was to then look at the results of the Oncotype DX score 0 to 10, 11 to 25, and greater than 25, and to enroll 10,000 women. This clinical trial not only involved the United States, but involved several other countries, including Australia, Canada, Ireland, New Zealand, and Peru. The trial was actually closed, I believe, a couple of years ago, and so it takes time to get some of the initial results. The article that was just published in the New England Journal zeroed in on those low-risk patients with Oncotype recurrence scores of 0 to 10. In other words, what we affectionately call the low scores. You'll recall that the intermediate risk scores and then the high-risk scores are ones that we've looked at for several years in the results of the Oncotype assay. One of the main functions of the TaylorX clinical trial is to look at the intermediate risk score patients to determine whether they really need chemotherapy or not. We've known for some time from retrospective analyses that the low recurrence scores not only don't benefit from chemotherapy, but really don't need it at all. And we've also known that with high recurrence scores that patients not only need chemotherapy but benefit from chemotherapy. So the design of the TaylorX clinical trial was to look at those intermediate risk scores defined as 11 to 25 and then to randomize these patients to get chemotherapy plus anti-hormone therapy or anti-hormone therapy alone. Now, we're still waiting for the results of that intermediate risk group, but what's been reported in the New England Journal of Medicine is this low risk group of Oncotype recurrence scores of 0 to 10. It's also really important that you remember that the best data always comes from prospective clinical trials that randomize patients. Now, the only arm that had the randomization here was that intermediate risk group. However, the low-risk group is, of course, being tracked, as is anybody potentially in the high-risk group. So what were the results? What's so exciting about this? Well, the results were that at 5 years, patients had less than a 1% chance of having distant recurrent disease. This is really exciting news. It really validates once again that in the low Oncotype recurrence scores that patients do not need nor do they benefit from chemotherapy. Patients in this group of Oncotype scores clearly only need anti-hormone therapy. We're all waiting for the results of the intermediate risk group, but take to heart right now this important report from the New England Journal of Medicine that the low-risk patients only need anti-hormone therapy.
Hi, I'm Wendy Hartley, co-founder of Breast Cancer Answers. You know, not every breast cancer patient benefits from chemotherapy. When I was diagnosed, my doctor thought I would need chemotherapy. But then I learned about the Oncotype DX test, which helps your doctor decide if chemotherapy could benefit you based on the unique biology of your tumor. My test results revealed I had a very low chance of my cancer returning, which meant I didn't need chemotherapy after all. To learn more about the Oncotype DX test, click this button here.